Jane, thank you very much for the introduction, and Rick also, and congratulations to you, your committee, and Betty, and for your effort to bring this together. As Craig said, research is exciting when you live in Madison and can look out and see the lake every day. You certainly find this a wonderful place to live in and to practice. And what I want to talk to you about this morning is asthma exacerbations, clues to causes, mechanisms, and treatment. These are my disclosures. Again, I'm employed by the University of Wisconsin School of Medicine and Public Health and do some consulting work, but that should not interfere with what I'm going on. The research interests, they're paid for by the NIH. So let's set the stage. This is going back a number of years. Before we began our research, one of the first questions we asked was, what did the literature tell us about asthma exacerbations or attacks and their causes to direct our research? So what we did was go back to the 1920s to get some clues from relevant literature to give us some direction in this area. And this is going back to Christopher Robins. So Christopher Robin had weasels and sneezels. They bundled him into his bed. They gave him what goes with a cold in the nose and some more for a cold in the head. They wondered if weasels would turn into measles, if sneezels could turn into mumps. They examined his chest for a rash and the rest of his body for swelling and lumps. They sent for some doctors and sneezels and weasels to tell them what ought to be done. All sorts and conditions of famous physicians came hurrying around at a run. They all made a note of the state of his throat. They asked if he suffered from thirst. They asked if the sneezels came after the weasels or if the first sneezle came first. They said if you thiesel a sneezle or weasel, a measle may easily grow. But humor or pleasel a weasel, a sneezle or weasel, the measle will certainly go. They expounded the reasons for sneezels and weasels, the manner of measles when new. They said if he for thiesels and draughts, and if in breezels, then for thiesels may even ensue. Christopher Robin got up in the morning. The sneezels had vanished away, and the look in his eyes seemed to say to the sky, now how to amuse them today. And that's my job, to amuse you at least over the lunch hour. I think going back to 1927 in this poem, a few things are very relevant. First of all, respiratory infections can have effects on lower airway functions. The most common cause of an upper respiratory infection is a common cold. And so what we did was to try to find out how a common cold, which is innocuous for most of us, can lead to profound effects in the lower airway, leading to very severe exacerbations of asthma, which will require for many people hospitalizations, aggressive treatment, and can even be leading to death. So what I'd like to do is trace with you what we've done over the last few years, both here and elsewhere, to get an idea of how we can bring these two things together. You've already heard a lecture this morning from Jim Gurn on Rhinovirus C, which is the common cold virus, and really a new common cold component, which is very important in asthma. So that as a background, I think we've got good ideas of the role of respiratory infections in asthma. We know we have some data largely from here that healthy infants, particularly if they're at risk for allergic disease, if they can get respiratory infections early in life, the first 3 years of life, and the respiratory infection can do this, and they're allergic, they're likely to go on to have asthma for the rest of their life. There's also increasing data that individuals who have asthma and get a respiratory infection, and here we're talking about mycoplasma, chlamydia, or even rhinovirus, can lead to worsening of their disease and make the disease more severe and more persistent. But what we're going to be talking about today is the person, the child or adult who has asthma, and they then get a respiratory infection, and this can lead to an exacerbation of asthma, which I said can be severe enough to go to the emergency room or emergency department or even need hospitalization, and in many cases requires prednisone to prevent the progression of the disease. So let's look at what factors can determine if a respiratory infection provokes asthma. We're from Wisconsin. We're an agrarian state. So I'm going to break this down into an agrarian situation. Let's first of all look at the seed. And here we're talking about the virus type, and we'll talk very briefly about the rhinoviruses that seem to be most associated with asthma. Talk about the load, getting down to the lower airway. For years we thought because the rhinovirus replicates best at 33 degrees, it can't be infecting the lower airway. That's not correct. Bacteria have also taken some interest in this area. I won't talk about it, but there are data that the microbiome or some bacteria may follow viral respiratory infections and be an amplifier of this, but viruses seem to be the inciter. The second component agrarianly is looking at the soil. So for the seed to act on the soil and to grow into a plant, the soil has to be right. Not everybody with a respiratory infection that has asthma will go into an exacerbation. The conditions have to be right. And we know for the virus to replicate, it goes into the epithelium. And setting the soil to be receptive to the seed seems to be influenced by the level of inflammation. Eosinophils seem to be very important in this component, and how they are important isn't really known, but they're a marker of somebody who's at risk for an asthma exacerbation. We know that the first cell that is attracted during a rhinovirus infection, which then leads to asthma, is a neutrophil. And we don't know if these are bad or good. Are they cleaning up the virus, or are they really inciting the lower airway inflammation? I'll spend a lot of time on allergies and bring to your attention the fact that IgE-mediated components seem to be very important as risk factors. They may set the stage for inflammation in the airway, but they also may be influencing deficiencies in innate antiviral responses. And we'll talk about how these may be related to this. So when the conditions are right, it's the right virus, the right soil, the virus replicates, it goes to the lower airway, sets up an inflammatory process, the airway becomes more responsive, and an asthma exacerbation occurs. So this is what we feel is going on. So let's look at the soil. The University of Wisconsin back in 1974 was very important in moving the field forward in this regard. Prior to this time, although we knew that respiratory infections made asthma worse, most people thought it was bacteria, and the treatment was antibiotics. And this was a study done here in which we gathered 16 children, a small study. They were young, 3 to 11 years of age. They had a history of asthma attacks in the preceding year, usually 4 per year, with respiratory infections. And then secretions were gathered from their upper airway, and by culture they looked for the presence of viruses or bacteria. And they did this over a year period of time. And what they found was the following. The infection most likely associated with the attacks of asthma was a rhinovirus, and they included a variety of types. You know, they could get influenza. It didn't seem at this time to cause this. Haemophilus influenza bacteria was infrequently found, but it was rhinoviruses. And this was found to account for about 40% of the cases. And again, I'll show you data now that were far greater than this, but the culturing methodology is extremely insensitive, and I think although we identified the causative agent in this event, we didn't identify the importance, of this. So what do we know about rhinovirus? And Jim Gurn may have already introduced it. It's the most prevalent human pathogen. With PCR technology, we can pick up these infections very readily. And in 85% of the exacerbations of asthma in children, viruses are identified, of which rhinovirus is the most common, and also in adults in about 50 to 70% in asthma. And we also see this in COPD. We also know that these events are seasonal. There's a spike in the spring and there's a spike in the fall. The fall spike I'll talk a little bit later on, but it's when the kids go back to school when things really flare up for these youngsters. Until recently, there's been about 100 plus strains of rhinoviruses found, and that's why a vaccination for this is really not going to be feasible. And Jim Gurn and others have recently identified this new strain of rhinovirus called Class C. And the reason we're interested in it, it is depicted on this slide from studies down in Perth, Australia, in which they looked at the frequency of human rhinoviruses and other common respiratory viruses identified in about 128 children who were admitted to their hospital with an asthma exacerbation. As you can see, rhinovirus C was the dominant virus associated with the exacerbations of asthma. And again, no viruses were found very infrequently. So this is the one virus that seems to dominate the area. And the reason it was newly described was that there were not culture ways of identifying them, and molecular techniques were available to identify them. And then Jim and others have now been able to culture, and they've got ideas as to what the receptor is. So movement will be forth in this area. So viruses and rhinoviruses are the dominant infection that brings about these episodes. Let's talk about the soil. The soil, as I've already indicated to you, seems to be influenced by allergic inflammatory events. And there are a number of human model systems, and what I'm going to be talking to you largely about is human studies. And these are studies that we have done. So models to study asthma include bronchial purification. You can take an allergic subject, have them inhale an allergen, and what will happen is there will be a reaction in the lower airway, which you can measure on pulmonary functions, and you can also get secretions from the lower airway to get clues as to what are the cells, what are the patterns of the immune system that are regulating this process. We also know that when antigen is inhaled into the lung of patients with asthma, there are two phases of reaction. There's the acute reaction, which occurs usually within an hour. This is mediator release from mast cells acting upon the airway, histamine, leukotrienes, and again, this causes an immediate drop in lung function. It's due to the mediator release and the actions of the mediators on the airway smooth muscle. It's bronchospasm. However, in a segment of individuals, and it's highly variable, if they have asthma, there's a development of a late phase reaction. And this is related to the generation of cytokines and chemokines, primarily from lymphocytes, some from endothelial cells and macrophages, which then attract to the airway large numbers of eosinophils. And this late phase reaction is more akin to the inflammatory process that one sees in asthma. So although the immediate phase is interesting and causes symptoms, it's the late phase which reflects what's going on in the disease and is more reflective of chronic persistent asthma. So we are interested in that. So how did we study this and find out how viruses may be fitting in to regulation or modification of the asthmatic or allergic response in the airway? So what we did was take patients who had allergic disease or asthma. We experimentally infected them with a rhinovirus. This is a benign cold, and the illness is very time limited. We then, when they were infected, challenged them with antigen and then looked at the pattern of response to the antigen, both without the cold and with the cold. And here's what we saw. And the first question we tried to answer was, what effect does a rhinovirus cold have on the airway response to inhaled allergen? Well, prior to the cold, it was a small study, about 10 subjects. We brought them in, and the vast majority, when they didn't have a cold, had a very nice immediate response, but no late phase or inflammatory response. We then gave them a cold, challenged them again. We enhanced the immediate response, and also they developed this late phase reaction. So what happened is that the cold actually shifted the pattern of the allergic response from a more vigorous immediate response, which reflected mast cell mediator release, and then also into this inflammatory response. So again, later on we found that the virus is in the lower airway, but this is a simple cold in the upper airway which caused this change. The other thing that was interesting but not shown on this slide is we tested these people 4 to 6 weeks later, and they continued to have this late phase reaction. It wasn't just during the cold, it seemed to have some propagation of this response for a period of time, and then it effervesced, much like you see in people that have an asthma exacerbation. So the first observation we made is that rhinoviruses seem to interact or act in a facilitating way for this allergic reaction in the lower airway. And Rob Lemancy was the principal author in this, published back in 1989 in the JCI. So the next question we wanted to find out was, could we get a better idea of what was going on in the lower airway? And so what effect did a rhinovirus have on airway allergic responses? This was an aggressive study. So we studied these candidates at 3 separate times. Pre-infection, we did 2 bronchoscopies. The first bronchoscopy was done to introduce antigen into the lower airway, pull out the secretions, and then have them come back 48 hours later. And this was Bill Calhoun and Nazar Georgia. They went back into the same areas, got cells, and flew it out, and looked at what happened. We then brought them back a month later. We gave them a cold, did the same challenges, trying to find out what's happening in the lower airway. The virus is down there, and we can compare to this response. And then we also looked at them post-infection, about 4 to 6 weeks later. This was an aggressive study. It was done safely. But again, these participants had 6 bronchoscopies. So what we also did was some normal controls. These are non-allergic individuals trying to answer the question, could a virus have an effect on somebody that wasn't allergic? And here we're just looking at eosinophils in the airway, a marker of inflammation. So, and we also found that, and I'll come back to this when we get to the allergic subjects, in the normal individuals, nothing happened. They got a mild cold, but there was really no change in their lower airway inflammatory pattern. So with the patients with asthma or mild or allergic rhinitis or mild asthma, once we gave them antigen, we activated their mast cell, we could measure these mediators in the lavage fluid, and eosinophils are attracted to the airway. When they got an acute infection, as you can see, there was a marked increase in the number of eosinophils attracted to the airway. Mast cell mediator release was increased, but more eosinophils were present, indicating not only have we activated the immediate response, but we've also changed the late response by attracting more inflammatory cells. These are no doubt a reflection of this whole inflammatory process and may explain why in the patients with asthma with more severe disease, there's greater inflammation and therefore greater airflow obstruction. And 4 to 6 weeks later, these individuals continue to have this enhanced allergic response. On a few of these individuals, we went out to 3 months and it had resolved. So again, these were very, I think, key observations early on to indicate to us that there was an interaction that is occurring between viruses and allergy. Our original prejudice was, at least my original prejudice was, that it was the virus that was driving this. And you put a virus down and it does it. It didn't seem to be that way. The virus was no doubt a facilitator of events that already existed, and it was just amplifying what was going on. And you see this in many types of allergic reactions. So putting this together in a cartoon fashion, when antigen is introduced into the lung, we set up an allergic reaction, there's mast cell activation, there's eosinophils recruited, and it goes down to the lower airway and causes problems. When you add a virus to it and then re-challenge with the antigen, what will happen is you enhance both of these events. More mast cell mediator release occurs, more eosinophils occur, and what will happen, and certainly in the susceptible individual, is that lower airway inflammation is more likely to occur. So again, we could find these both from some of the challenge studies and then the bronchoscopy studies. So the soil is important. And when you add the virus to the soil in the susceptible individual, you seem to enhance the inflammatory response. So another question that is now appearing has been, is there something different in patients with asthma which really makes them susceptible to these events? If you or I get a cold, we're bothered for a few days and we're fine. But patients with asthma, at least some patients with asthma, this is not the case. So we're interested in whether innate immune responses, or the community is interested in whether innate immune responses are altered in asthma and a risk for asthma exacerbations. One of the first studies came from Sebastian Johnson and reported by Peter Wark here in the Journal of Experimental Medicine. And what they did was get bronchial brushings from patients with asthma or normal individuals, incubate them with rhinovirus. They'd look for replication. Apoptosis is the way when these cells die, they get rid of the viruses. And they also look for the generation of interferon beta, which would have antiviral effects. And what they found is shown here. Here's the incubation with rhinovirus 16. Here are the normal individuals, and this is looking at the increase in interferon beta. So there's, in normal individuals, from their epithelial cells, they generate interferon beta. In asthma, it was diminished. And it raised the question as to whether or not in asthma there is a defect in at least this antiviral response, which in some individuals makes them susceptible to a virus, that they're more likely to get a cold, or when they do get a cold, that they're not more likely, but when they do get a cold, its effects are exaggerated and they may persist for a longer period of time. So is the pattern of what is the pattern of an antiviral response to a rhinovirus inoculation? And let me take you through some work that Jim Gurn and I have done. So what happens normally, what we did here was take allergic individuals, nasally infect them with rhinovirus, and we got sputum samples from them over a 2-week period of time. As you can see, very early on in the cold, there's increased generation, in this case of interferon gamma, as a reflection of this antiviral response. And if you look at the rhinovirus replication in the lower airway, we find that this goes up at 2 days, goes down to 7 days, but also at day 14, there's a high degree of variability. The recovery is very variable from patient to patient, as indicated by these wide air bars here. So the question we asked is it possible that there's a relationship of Th1 to Th2 in response to the severity of the cold? Years ago, the T lymphocyte system was divided up arbitrarily into two areas. Th1, which was protective immunity, sort of the interferon-driven response. Th2 is the allergy, IL-4, IL-5, IL-13, eosinophils, mast cells, IgE sensitization. And arbitrarily what we did was look at the ratio, IL-5 representing Th2 and interferon gamma representing Th2, which would be host protective system. And what we found was looking at symptoms. If you had a movement more towards a Th2, you tended to have more symptomatology. But if you had a drift to Th1, which would be more interferon generation, what is happening is in these individuals that their cold symptoms are reduced because they're producing more antiviral responses. In addition to that, we looked at retention of virus in the lower airway in relationship to Th1 and Th2, very arbitrary. And these are looking at these ratios in these individuals. And as you can see here, if they had a good Th1 response, at 14 days, virus wasn't detected. But if they had more of a Th2 response, that is the allergic response, and possibly a deficiency in the Th1 response, that the virus was going to be lingering in the lower airway. So not only do they have more symptoms when they get infected, but they also seem, at least some of them seem to have a greater persistence of viruses in the lower airway. And if they're there for mischievous reasons. Well, let's move now to try to solidify whether there's a relationship between IgE sensitization itself and risk for an asthma exacerbation. And this is a paper that came out of the University of Virginia in which they looked at children living in Costa Rica and went to the emergency room and tried to find out what role rhinoviruses was playing when they got a respiratory infection and looking at their state of allergy and how these two interplayed with one another. So they wanted to, like I said, evaluate the contribution of rhinovirus infections and their allergic status to the wheezing episodes, and they had about 300 children involved in this study. So here we have children who had no rhinoviruses. And as you can see, as their IgE titer increased, that is that they're more allergic, their probability of wheezing increased. However, if rhinovirus was present and they were allergic, the curve was shifted and they had a greater likelihood, indicating, again, that rhinovirus seems to be a facilitator of the likelihood that when you have allergies and you add the virus to this, that you're more likely to have an asthma exacerbation. One of the other questions, and I'll come back to this at the end of my presentation, we'll try to tie some of these things together as to get a better insight into how these things are going. We asked people around the country were beginning to ask questions. Are there interactions between IgE itself and antiviral responses? And to do this, Michelle Gill, who's at the University of Texas in Southwestern, looked at populations of dendritic cells. There's myeloid and there's plasmacytoid dendritic cells, and they can be obtained in small concentrations from the peripheral airway. And what she wanted to do is to look at how these cells may function in regulating antiviral responses. So she added viruses, and through the secretion of type 1 interferon, in this case alpha interferon, when these cells are activated, she could measure whether there were differences in cells from normal or in cells from allergics, and how IgE may be having a role in this response. So here's the first study. So first experiment she did is she added influenza to dendritic cells from controls and from normals, and as you can see, and from asthma, and as you can see, influenza did not stimulate the generation of interferon alpha to the degree that normals. And the same thing happened when Rhinovirus 16 was added. This is the same virus that we have been using to infect our individuals here. So in asthma, there seems to be a deficiency of these dendritic cells for releasing an antiviral interferon response, in this case, alpha interferon. And she looked at the diminished response in relationship to their serum IgE. Serum IgE has an equilibrium with IgE on cell surfaces. So what's in the serum is what's on the cell surface. And the higher the concentration of IgE, the lower the generation of interferon alpha when these cells are exposed to rhinovirus. And the same thing with influenza. So the presence of IgE on the cell surface seems to diminish the ability of these cells to generate this antiviral response. We don't know if it's just stoichiometric, that is, there's too many receptors on the cell surface and the virus can't get there. Are they blocking the receptors, or are they blocking something distal to the membrane and altering the signaling transduction pathway that occurs? It's not known at the present time. But again, it indicates further evidence that IgE is playing a role in not only preparing the airway by inflammation, but also by having a diminished interferon response. In animals, you can knock out systems selectively and very, very well. In humans, you can't do that, at least not at the present time. So what would happen if IgE is knocked down, or knocked out with an anti-IgE molecule? Omalizumab is a monoclonal antibody against IgE, and it's humanized. It binds to the Fc portion of IgE, and it blocks the attachment of this antibody to the cell surface, mast cells, basophils, and other cells. And administration of this can actually be a clinical human model for a knockdown of IgE, because IgE is removed from the circulation, it's removed from the cell surface, and you can correlate this with clinical outcomes, and you can correlate this also with in vitro evidence. So it's one way, not a perfect way, but one way to get insight into what happens if you remove what you think is the putative antibody that is related to these effects. So we were involved in a study through Intercity a number of years ago looking at what happened with omalizumab when we treated children with asthma living in the inner city. Relatively large study, 400 kids. Prior to randomization, we established control through guideline care, and we kept this up. So their asthma was well controlled. It was not, they didn't get exacerbations because they weren't treated. And we compared omalizumab to guideline care. So what were the effects? Well, here are the individuals treated with guideline care. In the spring and in the fall, there was an exacerbation. This is despite ongoing good control of their asthma. And to our somewhat surprise, we really knocked out, to some degree, the spring spike and also the fall spike in asthma. And we got nasal secretions from these kids, and these exacerbations were caused by rhinovirus. So what it suggested was we didn't prevent the kids from getting a cold, at least from this study we didn't prevent them from getting a cold, but we prevented some of the consequences that happened after they got a respiratory infection. So it suggested the following events are occurring. Epithelium. Epithelium gets infected by a virus. If the individuals are allergic, and this is supposed to be a cockroach, and it interacts with the mast cell, it releases its mediators, you put the virus in there on top of it, and because they have asthma, they seem to have a diminished capacity to generate this antiviral response. This is theoretically and speculative, and what this leads to is an asthma exacerbation. When you add omalizumab, you're blocking the allergic response, and this seems to have somewhat of an effect on reducing the likelihood of an asthma exacerbation. So what contribution does IgE make to a respiratory virus-provoked asthma exacerbation? So when IgE is elevated, inflammation is increased, virus replication seems to be diminished, and an asthma exacerbation occurs. If you normalize or reduce IgE, you do reduce inflammation, and we participated in a study a number of years showing by bronchoscopy that the inflammatory response is reduced, and we speculate that virus regulation is improved, and what happens is an exacerbation is less likely to occur. So, to extend this, and these are unpublished data at the present time, we did a study, it was called the PRO study, preventative omalizumab or step-up therapy with inhaled steroids to prevent fall exacerbations, the PRO study. Randomized study, did it over 2 years. It had to be done over 2 years because we had 9 sites, we enrolled about 500 kids, and we timed the administration of omalizumab or increasing their steroids to about 4 to 5 weeks before they went back to school. So it was a little chaotic as the kids were going back to school. They had to come in. We stabilized them, brought them in, gave them their injections or increased their steroids, and then also continued that over the next 4 months. The reason we picked the fall is because the fall has now become known as the time of September epidemics. And these are data from Canada, in which from 1990 to 2004, and it continues today, they looked at the hospitalization rate for asthma in children 5 to 15 years of age living in Canada. And as you can see, each fall, there's this spike, and it happens about 2 weeks after the kids go back to school, like clockwork. As you can see, there's some variability, but year after year after year, these are the events that happen. And I showed you this on this line graph before, that what we saw. So we timed this, for the fall. So in this study, we identified kids in November through July. We did a run-in with them. We really got their asthma stabilized. Timing it to when they went back to school, they were randomized to either continue on guideline care. If they had low doses of inhaled steroid, we boosted their dose of inhaled steroids, or they got an injection with omalizumab, and then we followed them over the next 4 months. I'm only going to go over the data with omalizumab on you because it's relevant to the topic I'm talking about. So what happened? The kids that were getting guideline care or placebo had about a 20% frequency of asthma exacerbations during this 4-month period of time. If they got omalizumab, it was reduced by approximately 50%. Again, through some of the same no-doubt mechanisms that we showed before. The other question we tried to address was who's really at risk for this. This is going in step 2 to 5. Step 2 is a low dose of inhaled steroid. Step 5 is high dose inhaled steroids and long-acting bronchodilators, maximum therapy for these children. At step 5, which is the highest therapeutic treatment of their disease, the greatest benefit was achieved with a reduction of about 60%. So the children who seem, at least one of the groups of children who seem to be at risk is more severe disease. And one would speculate, and we've got some evidence to suggest that they have higher circulating eosinophils. They know to have higher exhaled nitric oxide, which would also be a marker of airway inflammation. Because they have more severe disease, they've got a greater inflammatory process in their lower airway, and which no doubt would make them susceptible. The other thing we looked at was what happens to kids that have had an exacerbation during the run-in. Have they somewhat primed their pump by having had an infection? If they had no recent exacerbation and ended the blinded phase and got omalizumab, nothing much happened. If they didn't have an exacerbation, they seemed to be a non-exacerbator, and what we did made no difference because they had no problems. However, if they had had an exacerbation coming in, and whether this reflects non-healing of the airway or other events going on, we found that omalizumab really improved them considerably with a reduction of about 80%. So again, severe disease, recent exacerbation, and again, all of these kids had allergy. So the next question we asked was, does omalizumab have an effect on dendritic cell generation of interferon alpha? As I told you, Michelle Gill had seen that if she took dendritic cells from patients with asthma and incubated them with rhinovirus, their secretion of interferon alpha was diminished, and it related to the concentration of IgE, no doubt, on their cell surface. So what we did in this study at 2 sites was to draw blood on these kids before they started study, at the end of the study, and we looked at a number of parameters. Primarily, what was the change in generation of interferon alpha, and did omalizumab have any effect on this? So pre-treatment, these are all asthma kids. They got placebo or they got omalizumab. The numbers are fairly large for doing this study, and they're very similar and depressed from what we do see in the normal. With post-treatment, what we saw was that there was this is looking at the IgE receptors. So the IgE receptors are high on the cells of these individuals post-treatment with omalizumab, it's reduced because the serum IgE goes down and the IgE comes off of the cell surface, and these cells are now sort of stripped of this antibody. The next thing we looked at was the generation of interferon alpha. I was getting ahead of myself here. So pre-treatment, those assigned to placebo, those eventually assigned to omalizumab, they generated the same amount of interferon alpha. However, after treatment with omalizumab, when the IgE was lowered and it was lowered on their cell surface, the amount of interferon alpha increased. So we seem to have restored this antiviral activity. The next question we asked ourselves was, does this have any clinical relevance? The numbers aren't large, but what we looked at was taking a median level, sort of at a cut point. If they had less than the median level of generation of interferon alpha, their exacerbation rate was around 20%. If they were higher than this, means generating more interferon alpha, their frequency of asthma exacerbations was significantly reduced. It's an association, it's a correlation, it's not cause and effect. But it certainly relates to the possibility that one of the reasons why asthma exacerbations is not occurring when you knock IgE down is not only have you reduced the intensity of the allergic reaction, but you may have also reconstituted or restored this antiviral activity. So what effect does IgE have on antiviral activity? Here's the native state. Allergic individual, a lot of IgE on their cell surface. It's usually cross-linked by an antigen. You put rhinovirus in there. Interferon alpha is not generated to a large degree. And we think that this may relate to an asthma exacerbation. And omalizumab strips off the IgE, and for reasons which we don't know, when this happens, interferon alpha is restored, asthma exacerbations are less likely to occur. So cartoon-wise, how can we put this together? Well, epithelium is the target. We bring our antigen in, sensitize mast cell, activate this with antigen, and if this is occurring in a patient with asthma, the interferon alpha generation is diminished, and the antiviral effects are reduced, and the allergic reaction is more likely to occur, and exacerbation occurs. If, however, we add omalizumab to the system, again, a probe for knockdown of IgE, there's less IgE, there's less of an allergic response, and we also speculate that what we are doing is reconstituting this innate response to the virus by causing an increased generation of one of the type 1 or type 3 interferons, which can be antiviral, and we may make the intensity of the cold less, or the consequences of the cold lessened on the immune response, and as a consequence, that asthma exacerbation is less likely to occur. So I think we've really gotten some insight into a number of things. So looking at what's happened over the last few years ago, nobody really cared about rhinoviruses. You got a cold, you knew you couldn't do anything about it, and you tried, chicken soup and a lot of other things to get it better. Rhinoviruses have become the king in the asthma, field. They are strongly associated with asthma exacerbations, and they seem to have a very important facilitating role as far as the inception of asthma, and we haven't gone over that. IgE sensitization and underlying allergic diseases are major risk factors for rhinoviruses to cause asthma exacerbations in some patients, and it's important to identify those. And IgE-associated defects in innate antiviral function can be a susceptibility factor for rhinoviruses, and therefore treatment directed towards mechanisms of IgE sensitization, such as omalizumab, and it's not an endorsement for omalizumab, this is a drug, but it also gives us a molecule for treatment, can reduce a susceptibility to rhinovirus effects. Maybe not the cold, though we have some evidence that that may be the situation, and as a consequence, prevent asthma exacerbations from occurring. When I'm speaking up here, I'm speaking for what we have done, and things just don't happen, as all of you know, by single individuals. Gregor Mendel was years ago, and looking at the genetic aspects was one person, one thing. It's a team. And again, I've been very fortunate to have wonderful co-investigators, Jim Gurn, Rob Lemansky, Nazar Jadur, Paul Burdix, and Carl Buckner and Arnie Rowe and also Chris Sorkness in the audience. I had mentors, Charlie Reed, Elliot Dick, who were really very helpful in this area. Research staff over this period of time has been great. You don't do research in isolation in facilities. And again, the chairs of medicine that I've had over the many years I've been here, beginning with David Graham and also with Rick Page, have been very important and supportive of this, along with Deans Phil Farrell and Bob Golden. Fortunate to get NIH support, and the Intercity Asthma Consortium really has been a wonderful source for having us being able to do team research, having us work together, both facilitating the clinical aspects and then being able to do translational research with us. So, Jane, thank you for inviting me to give the talk, and thank you all for attending today.